Amlodipine is one of the most prescribed medications in the world. Tens of millions of people take it every day for high blood pressure and chest pain. And if you are one of them, you may have noticed that your ankles swell, sometimes significantly, by the end of the day. You may have been told this is cosmetic. You may have been told to eat less salt. You may have read alarming things online suggesting your medication is secretly destroying your heart. Today I want to give you the honest, evidence-based clinical picture. What amlodipine actually does and why it works so well, why the ankle swelling happens, and the specific mechanism that most doctors do not take the time to explain, what the research says about managing it, and one genuinely useful thing amlodipine does for the urinary system that almost nobody talks about. No fear tactics, no exaggeration, just the science, from a urologist who works with vascular health and urinary function every day. My name is Dr. Elizabeth Kavaler. I am a board-certified urologist and urogynecologist with over 20 years of clinical practice. Amlodipine comes up regularly in my clinic, both because my patients take it for blood pressure and because calcium channel blockers have effects on the urinary tract that are clinically relevant to what I do. Everything I share today is grounded in published pharmacological research, including studies from the American Heart Association, the British Journal of Clinical Pharmacology, and the NHS Specialist Pharmacy Service. Amlodipine belongs to a class called dihydropyridine calcium channel blockers. Here's how it works. Blood vessel walls contain smooth muscle cells that contract to narrow the vessel and relax to widen it. Contraction requires calcium ions to flow into the muscle cell through specific channels. Amlodipine blocks those channels in arterial smooth muscle, preventing the calcium influx that drives contraction. The arteries relax and widen. Blood pressure falls. The heart works against less resistance. Blood flow to the heart muscle itself improves. Amlodipine has been studied in some of the largest cardiovascular trials ever conducted. The ALLHAT trial, with over 33,000 participants, found that amlodipine was as effective as or superior to other antihypertensive classes in preventing heart attack and stroke. It has a long half-life of 35 to 50 hours, meaning one pill per day maintains stable blood levels with no dangerous peaks and troughs. It is genuinely one of the safest and most effective medications in cardiovascular pharmacology. That clinical context matters, because when we discuss its side effects, we need to weigh them against the enormous benefit this medication provides for the people who need it. The ankle swelling that amlodipine causes is real, common, and has a specific mechanism that is worth understanding properly. Amlodipine relaxes smooth muscle in arterioles, the small arteries that feed the capillary beds. But it has much less effect on the veins that drain those capillary beds. This creates an imbalance. More blood flows into the capillary network through the dilated arterioles than can efficiently drain back out through the less dilated venules. The result is increased hydrostatic pressure inside the capillaries, the tiny vessels where fluid exchange between blood and tissue occurs. When capillary pressure rises above a threshold, fluid is pushed out of the blood vessels into the surrounding tissue. This is called fluid extravasation. In the legs, gravity concentrates this effect at the ankles. A study published in the journal Hypertension confirmed this mechanism directly. Amlodipine blunts the normal postural vasoconstriction reflex that prevents fluid from accumulating in the lower legs when you stand. When you sit or stand for long periods, this effect compounds throughout the day. This is not a sign of heart failure. This is not your body bleeding to death. This is a predictable pharmacological consequence of how calcium channel blockers work on the peripheral vasculature. The important distinction is that amlodipine-induced edema is a different mechanism from the fluid retention of heart failure. And that distinction determines what actually helps. Here is something clinically important that is rarely explained clearly. Diuretics, water tablets, work by reducing overall fluid volume in the body. They help edema caused by heart failure or kidney disease, where the problem is fluid overload. But amlodipine-induced edema is not caused by fluid overload. It is caused by increased capillary pressure forcing fluid into the tissue locally. The NHS Specialist Pharmacy Service and multiple clinical pharmacology reviews confirm that loop and thiazide diuretics have little reliable effect on calcium channel blocker-induced edema because they address the wrong mechanism. What does have clinical evidence? Adding an ACE inhibitor or an angiotensin receptor blocker, an ARB, to the amlodipine has been shown in multiple studies to significantly reduce the ankle edema. Research published in Hypertension Research found that adding an ARB such as valsartan to amlodipine therapy significantly reduced ankle-foot volume and capillary tissue pressure compared to amlodipine alone. The mechanism is not fully understood, but likely involves venodilation that restores the arterial-venule pressure balance. Dose reduction is another option. The edema is dose-dependent, with 10 milligrams causing more swelling than 5 milligrams. And in some cases, switching to a different calcium channel blocker in the same class, such as lercanidipine or licidipine, produces less edema due to differences in their vasodilatory profile between arterioles and venules. None of these changes should be made on your own. They require a conversation with your prescribing physician. But they are all evidence-based options worth discussing, and now you have the language to raise them specifically. As a urologist, I want to add something that no other video on this topic covers. Calcium channel blockers, including amlodipine, also affect smooth muscle in the bladder, specifically the detrusor muscle that contracts to empty the bladder. This relaxant effect on bladder smooth muscle can reduce bladder contractility. In men with urinary retention or difficulty emptying the bladder, this can worsen symptoms. In women and men with overactive bladder, however, the same smooth muscle relaxation can actually reduce urgency and frequency. Research has explored calcium channel blockers as potential treatments for overactive bladder precisely because of this mechanism. If you take amlodipine and have noticed changes in your urinary pattern, either improvement or worsening, this is why. It is worth mentioning to your urologist or prescribing physician so they have the complete picture. If your ankles swell consistently on amlodipine, here's what to bring to your next appointment. Tell your doctor the swelling is affecting your quality of life and ask whether adding an ACE inhibitor or ARB to your regimen, if you do not already take one, might reduce the edema while maintaining blood pressure control. Many patients are already on combination therapy and may be candidates for adjusting the ratio of medications. Ask whether your current dose of amlodipine could be reduced and whether a lower dose would still adequately control your blood pressure. Ask whether a different calcium channel blocker with a more balanced vasodilatory profile might produce less peripheral edema in your case. What you should not do is stop amlodipine abruptly without medical supervision. Calcium channel blockers should always be tapered under physician guidance. And please do not let alarming online content convince you that a medication your doctor chose carefully for your specific cardiovascular picture is secretly destroying you. The evidence for amlodipine's effectiveness and safety over decades of use is extensive and robust. Amlodipine is not a dangerous medication. It is one of the most beneficial cardiovascular drugs available, supported by decades of trial data and taken safely by hundreds of millions of people worldwide. Its ankle swelling side effect is real, sometimes significant, and has a clear mechanism. It is also manageable through evidence-based approaches that your prescribing physician is well placed to guide you through. You deserve an honest explanation of how your medication works, not a scare campaign. I hope this gave you that. I am Dr. Elizabeth Kavaler. I will see you in the next video.